It's a pleasure to be here today. I really appreciate everyone sticking with me. It's a long day, and you get to hear from another exercise physiologist with a shaved head and a beard that does PTSD research. Okay, so today I'm going to be talking about lifestyle interventions for traumatic stress, or what we lovingly refer to as LIFTs, and we're talking about treating PTSD by living the life of protein shakes and spot me's. I'm a federal employee, and so with that I have to disclose that everything I talk to you is a representation of my work and my opinions, and it doesn't necessarily represent the official policies or viewpoint of the United States government. I have no competing interests or influences to disclose, and I am currently funded by the Department of Veteran Affairs. Quick agenda, I'll talk a little bit about who I am. We're going to talk about some basics, make sure we're on the same page, which the good thing about today is I don't have to go extensively into details because we've heard a lot about this information, so I can just maybe fill in some gaps and we can breeze through some of this. And then we'll get into the rationale, evidence, and risk, and potential role of using exercise in the treatment of PTSD. I'm an exercise scientist. I was trained bachelor's through PhD in exercise science. I'm currently an investigator at the National Center for PTSD at VA Boston. And as mentioned, I do exercise and mental health research. What I think is unique about me in this role is my background. I'm not just an exercise scientist, but I'm a veteran. And I was really happy to see that there are some other veterans in the audience. I was a warfighter. I joined in the Army after 9/11. I was inspired. I was going to go to college, but I decided to enlist first before going to college. And I spent a number of years working as a warfighter or a door kicker. And the job required me to be fit, strong. You know, the picture you see on the right is me, and that is at 205 pounds, and I weigh in today at 155 pounds. So it's like a whole different person up there. But what is unique about my experience is that I liked to exercise. I've been an athlete my whole life, and while I was in the military, it was the same thing. I exercised to deal with combat stress. I dealt with the rigors of my job by staying in shape, decompressing in the gym, and a number of my battle buddies did the same. And we felt that was very potent at doing that. And so that kind of bit of information stuck with me over the years, and it's informed my research. In fact, it is the governing principle of why I do the research I do. There's me there. And so how did I get here from being a grunt? Well, after I got out of the military, I transitioned to civilian life and went to school studying exercise science. It wasn't very long before things kind of went off the rails. And personal disclosure, as a veteran, I have been treated for PTSD. I went through some of the treatments that you have learned about today, prolonged exposure being one of them. And I will tell you, it was probably the hardest thing that I've ever done, including being deployed to a war zone, but it was also one of the most rewarding because it works. That stuff works. So if you are a person suffering from PTSD or know someone who's living with PTSD, I highly encourage you to either seek out treatment or encourage them to seek out treatment because it works. Also, I wanted to figure out what I was going to do with my life, and when I was starting to recover from my own PTSD, tragedy struck. I lost one of my battle buddies to suicide. And at that moment, I realized I needed to do something. And I was not a psychologist, so what could I do with exercise? Well, I could study exercise and how it could be used to improve the lives of people suffering from trauma. So that kind of takes us to where I am today. As a member of the National Center for PTSD, what do? Well, I'm an ambassador to the fields of exercise science and trauma psychology. And so you've kind of heard this a couple of times today. So depending on who I'm talking to, if I'm talking to psychologists, I'm trying to tell them more about the benefits of exercise. If I'm talking to exercise physiologists, I'm talking about collaborating with exercise mental health providers, that sort of thing. I engage in a lot of community building exercises, breaking down professional silos, as do many of you here. We founded LIFTS recently. I think that was back in 2019. Simon, Michelle, several other folks in the audience are members of the LIFTS community. Basically, what we're trying to do is communicate and disseminate information around lifestyle interventions in the study of traumatic stress. And then I also leverage my military experience helping other veterans connect to mental health services, but also being a resource to other researchers and clinicians. Because I'm approachable, I am willing to talk about my experiences in the military, both good and bad. Okay, so now let's norm some stuff around physical activity. You've heard a lot about this, so I won't harp on a lot of it. Physical activity is all bodily movement, just to reiterate what we heard this morning. So all bodily movement is physical activity. All exercise is physical activity, but not all physical activity is exercise, because exercise is that intentional form of physical activity to improve your health. All activities have an intensity, a mode. Intensity is just how much effort you put into what you're doing. You can shovel dirt really easily, or you could do it vigorously. And I'm in the camp that intensity is key. I believe that effort drives a lot of the potential benefits and what we see in exercise outcomes. Mode is just how you do it. Are you running on a treadmill? Are you playing pickleball? Are you lifting weights? It's whatever way you decide to be active. And then MVPA is just jargon. It just means moderate to vigorous physical activity. And we've already seen this many times today. And I'll just say that most folks want you to be exercising at least 2.5 hours a week. And that is using aerobic modalities. On top of that, you should be lifting weights at least twice a week or doing muscle strengthening exercises in some way. And here's one thing that's pretty important. It's the same for most special populations. Whether you're older or you have different ability levels, you should be probably striving for those same amount of exercise minutes, but you just have to modify based on what you can do. You should still be working hard. This is one thing that hasn't been talked about today that I want to really drive home, that cardiorespiratory fitness, or your fitness level, is very important. And by engaging in an exercise program and improving your fitness level by 1 unit or 1 mat, which is relatively achievable by starting a new fitness program, it reduces your mortality by roughly 20%. That is impressive. There are a few interventions that will reduce your risk of all-cause mortality by 20%. And this is bidirectional. If you lose fitness, your risk of mortality goes up as well. Okay, so Kevin just told us a little bit about PTSD, so I'm not going to go through all of the details of what PTSD is, but I think it's important to recognize what trauma is, because we don't have a clear definition as of yet today what trauma is. So trauma is being exposed to actual threatened death, serious injury, or sexual violence. And this is through direct exposure, so you could live it. It could happen to others and you witness it, learn about it. And in the events of learning about it, it has to be a close family friend. It can't be something like watching it on television. And you can also experience trauma through your work, repeated exposures to adversive details of other folks' trauma. Examples of this is EMS workers, also social content media moderators are also exposed to a lot of horrific stuff. And if you're interested in the definitions of trauma, because this is a contentious topic in the world of PTSD, I encourage you to read more about it by Brian Marks and the DOIs right there. That's a really nice paper on the definition of trauma. Okay, so everyone who has PTSD has to experience a trauma, and then they have symptoms from the 4 main symptom clusters. And we've already covered this. The intrusions would be the flashbacks, the nightmares. Avoidance is key. It's cognitive or behavioral avoidance. Avoidance is typically described as the engine that perpetuates PTSD. People avoid and they don't get to rehab because of this avoidance. And then there's the mood and negative mood and cognitions, symptom cluster, guilt, negative views of yourself, the world, And then, of course, the classic arousal and reactivity symptom cluster. To reiterate some basic statistics, PTSD can affect anyone. It is not a sign of weakness. In fact, one of the things that I like to talk about is how trauma unites us. It is intrinsic to the human experience. Conservative estimates say that at least half of adults will experience one or more trauma in their lifetime. Other estimates say it's upwards of around 90% of folks experience a trauma. So trauma is common. 12 million adults each year live with PTSD in the US alone, obviously much more than that across the world. And it is in higher prevalence in certain demographics, veterans, first responders, forcibly displaced folks. And importantly, PTSD doesn't happen in isolation. People living with PTSD are at a much higher likelihood of having other co-occurring mental health conditions such as depression, alcohol and substance use disorders, binge eating, anxiety disorders, you name it. PTSD also affects functioning. Global functioning decreases. It's not just a mental health thing. PTSD is a systemic disorder that affects your whole body, your whole life. And so we see global changes in functioning, and this can manifest in reductions in physical activity, performance in your role, your life activities. And this can happen through the avoidance of public spaces, driving, crowds, areas where there's lack of control. We've talked about control quite a bit today. And then, of course, it can be further complicated by physical injury. Other ways it affects functioning, and we've talked a little bit about this again, is through negative changes in diets, binge eating as a form of coping or avoidance, instead of having access to it. Maybe so people may have difficulty going out to grocery stores as a result of their avoidance coping strategies, so they may order fast food, delivery, easy access food that isn't quite as nutritious, and other unhealthy coping strategies like substance use, tobacco use, alcohol, that sort of stuff. So the punchline is, what does it do besides having negative mental health outcomes? Well, we see a whole litany of physical health consequences as well. Obesity, cardiovascular disease, diabetes, hypertension, dyslipidemia, even premature mortality may be a consequence of chronic untreated PTSD. These data are a bit old now because this is pre-pandemic data, and you probably will have difficulty seeing this, but what this graph represents is cases of deaths among veterans with PTSD during the first year of treatment of their PTSD. Number one up there is heart disease. We've got cancers, we've got diabetes, liver disease, strokes, basically mostly things that are preventable through lifestyle intervention. So a picture's worth 1,000 words. I come from the rehab side of medicine, and so I'm a big fan of the ICF model for disability. Basically, it's a framework to understand how a disease or condition can affect different systems of functioning. And what we can see here, there's different, up at the top, we have the disease, we could say that could be PTSD. Body systems and structures are one level of functioning, your activity is another level of functioning, and participation in, say, like your job, your family, your role in society is another level of functioning. So different levels of functioning, and these are all interconnected and influenced by environmental factors and personal factors. And so an example of how PTSD could be disabling is, again, through the participation in society. PTSD is isolating. There is that fear conditioning that was already described today. It may manifest in an inability to go to work or go out, like I said, to the grocery store. And so you're unable to perform those levels of functioning, your impairments in your activities of daily living. So reductions in self-care, exercise, going to the gym or going to the park, due to feelings of lack of safety. And those sorts of lack of self-care could then drive negative changes in body structures and functioning, increases in body adiposity, poor blood glucose levels, hypertension, dyslipidemia. And of course, these are bidirectional effects, and they can be either hindered or helped by proximity to nearest healthcare centers, access to public and private transportation, personal factors like education, trauma type, history of TBI, and other co-occurring mental illnesses may further complicate this matter. And as Kevin just mentioned, there's different approaches to treating PTSD. And as I said, some of them are very effective. And I can speak personally to this, having gone through some of these treatments. But I can tell you that they're very difficult, and there are many barriers to success. Excuse me. I don't believe too much has been discussed about medications, but they, limited effectiveness, and they tend to mostly work while you take them, and if you stop taking them, they stop working. What's really critical about all of these treatments is none of them really directly address the physical health concerns. And some of them have side effects themselves that may drive those physical health concerns in the wrong direction. So, let's talk about the fun stuff, exercise. All right, so the rationale. I'm going to go through a summary of different potential physiological and psychological mechanisms. Some of them have been discussed by some folks here, so I'm going to give you a high-level overview of this. So we talked a little bit about habituation and desensitization, how this might work. And one potential approach to this for PTSD and exercise is, so if you imagine yourself at a theme park and you're looking at a roller coaster that is very scary. You get on it, it's thrilling, it's terrifying, and you have this big physiological reaction to that. When you get off, you calm back down. The second time you go on that roller coaster, it probably elicits the same or similar response. But if you ride that roller coaster about 15 or 30 times, it becomes business as usual. It becomes no longer scary. You get used to it. And perhaps by getting used to that roller coaster, you can then go on and get on a bigger and scarier roller coaster because you've developed a little bit of confidence. You might be able to apply that same logic to exercise. So what is exercise? It's a physiological stressor that activates the stress response system. It may not have the same cognitive load as something like being chased by a tiger or a trauma reminder or something that triggers your trauma memories, but a lot of the stuff that's happening inside your body is very similar. It activates you, your heart races, you sweat, you breathe heavy. And so by normalizing the experience of all of those interoceptive cues, you may actually get yourself a little bit better at handling stressful environments and situations. And so maybe by becoming physically trained, you are then more prepared to deal with a trauma reminder. So that's one way that you might approach this. Another way is through training adaptations in the endocrine system and the nervous system. So we've had people talk about this that are far more experts in this field than I am. But one thing that does happen is that when you exercise, going from an untrained state to a trained state, your body secretes different stress hormones at slightly different ways. And so it's possible that by becoming trained through exercise, that maybe it helps normalize some of the stress response systems, as PTSD is characterized as dysregulation through a lot of these nervous systems, namely the HPA axis. Another potential way you could approach at using exercise for the treatment of PTSD is through changes in brain structure and function. One of my colleagues in Texas, Mark Powers, and his colleagues did a randomized control trial several years ago where they looked at the potential of pairing exercise with PE, and they were really interested in brain-derived neurotropic factor as a potential mechanism here. And several folks have talked about this, but the outcome of this study was a randomized control trial where One group got PE alone, prolonged exposure therapy for PTSD, and the other group got PE plus exercise. I believe it was treadmill running. And the group that got the exercise condition fared better than the group that did not get the exercise condition. Again, this shouldn't be a surprise after all the stuff you've heard today. But what was interesting about this study is that there was an increase in BDNF from the exercise condition. And I believe this was moderate intensity exercise, which has been the kind of the marker of success. So by increasing, the thought process here is by exercising, they increase the flow of BDNF, which is a critical component in learning and consolidation, and that could help with the therapeutic process of learning, and that augmented the treatment outcomes from PE. Another potential way that exercise could address PTSD is through improvements in sleep quality. Those people who exercise more tend to sleep better. And so one of the hallmark symptoms of PTSD is poor sleep quality, nightmares, and insomnia. And in a study that we did a few years back, we looked at folks that were participating in exercise, and those folks that were doing strenuous or vigorous exercise tended to sleep better, and people who slept better had lower PTSD symptoms. Incredible. Another really fantastic potential way for exercise to improve PTSD, and this one is particularly interesting to me as it doesn't have a whole lot of research behind it yet, as with some of the other approaches, but is how exercises changes the way people view themselves. So one of the core components of PTSD is this negative cognitive appraisal of yourself or the world. And a lot of folks who have experienced trauma view themselves as broken, damaged, or victimized, or that the world is unsafe for them to be in because it is dangerous. And so there are these distorted cognitions of themselves and the world. So I ask you, what happens to someone who has those distorted cognitions where they think they're frail or weak or unfit for society? And you put them in the gym and have them lift weights, and they can see week to week that they're getting stronger and more fit. They can see it in the mirror, they can see it like when they're lifting the weights, they get faster, they get stronger. So how does that start to shape the way they feel about themselves? Do they feel like they are no longer weak? And does it make them more prepared to deal with the dangers of the world? I don't have answers to that. I think that's a compelling direction for research to go. Another excellent potential benefit of exercise is through the establishment of community, survivorship. We see this in groups like Team RWB, where you build a community, or esprit de corps through survivorship, brotherhood, sisterhood. You get to be with the people that have walked a mile in your shoes and share those experiences and heal together through physical activity, which is incredible. And this one's not quite as exciting, but this is like the take-home message right here, is exercising is going to reduce the risk of cardiovascular disease, diabetes, all-cause mortality. It also reduces the risk of depression, improves current depressive symptoms, reduces acute and chronic pain, the list goes on. So even if it really doesn't do anything for PTSD symptoms, which I'm not saying that it doesn't, there's rationale enough right here for it. And I would say something's better than nothing. And then also, it's what people want. We've heard about this already from some folks, is that they're really, really excited about exercise, particularly from Michelle's talk earlier, and actually you can see that, that's her right there, that's her paper. People who've lived experience with trauma want tailored exercise interventions to help them recover, which is awesome, and so we should give it to them. So what's the evidence look like? Well, this is a relatively new field, and with less than 10 years, I would say, maybe just about 10 years of RCTs. Mark Powers and Simon were of the first folks to publish RCTs, so that was what, 2015? Yeah, so about 9 years, not that long ago. It's hard to believe. We have a lot more observational research. that connects the dots for us. As I just said, we have a lot of direction to go, a lot of ground to make up with the experimental research. But folks with the diagnosis of PTSD tend to participate in less exercise and global physical activity. And then within the sample of PTSD positive individuals, people with higher severity of PTSD symptoms tend to do less physical activity and less exercise and have lower cardiorespiratory fitness. So just by proxy, would have a greater risk of all-cause mortality likely. Other psychological conditions also increase the risk of physical inactivity, and we know PTSD comes often with other psychological conditions. From this research, we also see the flip side of this, that increases in exercise, folks that are more active tend to have better PTSD symptoms. And to a degree, we see dose is probably important. We see stronger signals in higher intensity, moderate and vigorous exercise versus light intensity exercise. And what's critical to note here, that this relationship is probably bidirectional. It's not simple. There's a tug of war going on here. So folks who have a high degree of PTSD symptoms probably are going to struggle and have difficulty getting out and being active based off of their disabling condition. However, if someone can pull them along or they can find the drive to go out and exercise, it's probably going to help. Some sample of the research, experimental / meta-analytic research. Exercise as standalone treatment, small to moderate reductions in PTSD symptoms. It's not a panacea, folks. It may be pluripotent, but it's not going to fix everything. It is a tool in your tool belt. We see larger effects with depression, anxiety, and sleep. It was alluded to earlier that exercise and physical activity is and should be a frontline, first-line treatment for depression, maybe not for PTSD. Exercise combined with therapy, well, we see better effects with exercise combined with therapy than with therapy alone, so it's likely able to augment those effects, as Kevin's really digging into with his research. Mode and intensity. Well, we don't really have any direct comparisons to my knowledge of different like resistance training versus aerobic exercise. We have intervention to intervention comparisons with meta-analytic research that seem to favor aerobic over resistance training. I'm not fully convinced at this stage in the game until we actually get those direct comparisons, but we do see larger effects with higher intensities. The dose effect of exercise is poorly understood, and we need a lot more research. But I would argue that it really probably doesn't matter what is the optimal dose of exercise for PTSD, because we have a crisis of physical inactivity. People know that exercise is good. And it doesn't matter if high intensity continuous training is the best. If someone's not willing to do it, then it doesn't matter. So we need to meet people where they are. This is where those tailored physical activity interventions come in. We figure out what they want to do, we get them doing it, and it's probably going to help. Acute effects. Again, Kevin talked a little bit about the acute effects. I'll talk more about the enjoyment of joy of exercise during exercise. So this is an interesting study that was a bouldering study. Well, 3 groups here. We had a bouldering group, we had a Nordic walking group, and a social contact control. And for those of you that are unfamiliar with the circumplex model, the circle is basically on the y-axis, you have your perceived activation, which higher degrees of activation just mean your heart rate is elevated, you're kind of activated, you're feeling kind of jazzed up. It doesn't have like a positive or negative to it on its own, but that's where the x-axis comes in, where the affective valence scale, 0 would just be feeling neutral, positive numbers would be feeling good, and negative numbers would be feeling bad. So if you're high aroused and feeling very negative, that'd be like anxious arousal. Whereas positive activation and positive valence would be excitement. You're like really happy, feeling good, you're jazzed about something. So we see in a pre-session, mid-session, and post-bouldering session analysis of their activation and arousal, or their activation and affective valence, people started more neutral. They felt good during the climbing exercise, and then they continued to feel good, but their activation came down at the end of the session. And we see in the Nordic walking and the social contact control, there's less movement in those domains. So basically, during exercise, people felt really good. Here's a study that we did a few years ago. This was resistance training in primarily trauma-exposed women. Same basic findings is that people were more neutral, but in the exercise condition, they felt good during exercise and after exercise, and they got activated, which is also good. To complement this, we also had some acute measures of distress. So pre, mid, post session, their distress levels went down. There was a bit of a rebound between sessions. Next session, they went down further, a little bit of a rebound. And then finally, in the final session, the exercise group in red kept going down, down, down. So they started at a high level of distress, and then they experienced progressively less and less distress over the course of an intervention, a resistance training intervention. And what does this all come together to mean? Probably can't see this, but what we found is that these changes in feeling and distress, their affective valence and their distress predicted changes in their PTSD symptoms. So the more people felt good and less distressed during exercise, that predicted decreases in their PTSD symptoms over time. So the take-home message is exercise and treatment for PTSD doesn't have to be noxious. It could be joyful. People could have a good time and enjoy the experience and see positive changes in their PTSD symptoms. All right, so I just summarized that. Sounds great, but what are the risks? What are the concerns? So one of the things I hear from survivors and clinicians alike is concerns of symptom exacerbation. And Simon touched on this earlier. There's just really no evidence to support that exercise is going to exacerbate PTSD symptoms. There may be certain situations that might exacerbate PTSD symptoms, and so this goes into the trauma-informed efforts, making sure that space, coaches, and survivors are aware of what's coming. And so I think that's important to recognize. But to date, I'm not aware of any iatrogenic effects of exercise on PTSD that are limited to PTSD. So what's the most likely worst case scenario? Is that it doesn't do anything for PTSD symptoms. However, and even in that situation, it does a ton of other good for things that are important for folks with PTSD, namely those physical health conditions, depression, anxiety, poor sleep quality, the list goes on. So what's the likely best role, or what's a potential approach for using exercise in PTSD treatment? As I mentioned, it's not a panacea. You might have some limited success as a standalone coping strategy because it's low risk. It doesn't involve a highly trained provider. It can be done individually at little or no cost. And if you are a frontline fitness provider that doesn't have a ton of experience with this sort of stuff, but you know your patients use you as a psychiatrist or a psychologist, it's a foot in the door opportunity. You're getting them fit, and you can be that referral mechanism. You have established a relationship with them, get them to see a trained mental health provider. Also, it's clearly has value in augmenting current evidence-based practice in medicine through prolonged exposure therapy and other modalities. It's likely best applied as a comprehensive tool in a healthcare lifestyle approach. So if you are interested in this field and you want to help, as I alluded to, there's a lot of work to do. It's a new field, only 10 years, 9 years of RCTs. Pick a direction, run with it. Treatment development, mechanisms, study the exercise parameters of dose, implementation. Sky's the limit, we need you, get involved. Okay, the 2-minute takeaway here, because I want to save a few minutes for questions and discussion. Rationale is that Exercise and mental illness reduce people's ability and desire to exercise, which increases their risk for disease and disability. Doing exercise for 2.5 hours or more a week, plus 2 days of resistance training would be awesome, but something's better than nothing. Exercise is safe. Do it. Get your friends, family, and patients doing it. The evidence, well, exercise, the research supports exercise can reduce PTSD symptoms. Maybe not a ton, but there's some support for it. There are larger effects on sleep quality, depression, and of course, the risk of physical health consequences. As I mentioned just a moment ago, the role, it's a healthy coping strategy that likely could be fit into any number of evidence-based practices. All right, with that, I'll show you some puppy pictures and I'll take questions. I know we're all tired. Someone's gotta have a question.
Yeah. No, go ahead. I was going to introduce the Q&A. Go for it.
Thank you, Dr. Whitworth. I was wondering if you have seen positive, outcomes among people who expose themselves to stressors purposely, such as exercise or like the roller coaster that you had mentioned. I know cold plunges have kind of increased in popularity, as well as even like different types of breathing, hyperventilation and such, but with a timed kind of specificity. Have you seen a positive outcome for individuals to respond to stressors in their lives if they expose themselves to stressors purposely?
Well, my name is James. I know I'm not big on titles. Just to reiterate your questions for the web-based folks. People exposing themselves intentionally to different types of stressors, like exercise and other examples, like different breathing exercises, is that therapeutic? Well, I mean, exposure is the basis of much of what we use to treat PTSD and anxiety disorders in general. And I don't even know that you really need to have awareness of that for it to be therapeutic. So one of the studies I had up there was the resistance training study where the joy of exercise. So that study, the participants weren't told that it was a PTSD study. They were screened for PTSD. It was an exercise study. And we didn't tell them that we're using exercise to treat anything relating to their mental health until there was a debriefing at the end. And we saw improvements in a whole list of mental health conditions like depression, anxiety, the sleep quality, PTSD, and they were unaware of it. And it was an interoceptive exposure. We didn't tell them that they were using this to improve their PTSD symptoms. So yes, I think absolutely.
May I ask one more question?
Yeah.
Okay. Among veterans or maybe even non-veterans, have you witnessed any more compliance or adherence to exercise routines when they have a buddy, when they have a group of people or at least one other person who might, hold one another accountable, or they meet every Monday at the same time? Have you seen any difference among solo or paired workouts?
So the question is compliance to exercise programming better with when it is designed to include battle buddies or other family members? I haven't done any of that research, but I will say that exercise compliance in the studies that I've done has been very high, 80 to 90%, which is already higher than traditional forms of treatment, which attrition rates we see around 30%. But one of the biggest points of feedback from the interventions that I've done, which were solo one-on-one, is I want to do it with a buddy. So I can't say definitively yes, but I will say that it's something that people want, and so we should give it to them. I think that is a huge opportunity right there, for support back and forth, and I believe that it would increase compliance, yes. Yep, of course.
Do you have seen any evidence of there being a difference in treating PTSD with exercise if the participant is exercising outdoors or indoors?
Ooh, that's a really good question. So the question was, is there a difference in PTSD outcomes versus indoors or outdoors? So we've heard about the blue gym and the green gym today. I can't speak intelligently about whether or not there are differences, but there are, I think, because I don't know if there are any direct comparisons. And if someone in the audience does know, they feel free to chime in. But I know that a colleague of mine out in the Naval Health Research Center in San Diego, Kristen Walter, does PTSD depression research with veterans and active duty soldiers. And they primarily get people surfing and hiking, and they've seen tremendous therapeutic benefits. So whether or not it's better or the similar, I can't tell you, but there are significant benefits for getting people outdoors and getting them active in different spaces. I honestly, if it were my opinion, it would be meeting people where they're at, what they're capable of doing. So if someone is willing to go hiking for a form of therapy, then I'm all for it. You know, it doesn't have to be 20 minutes sweating on the treadmill.
Thank you.
My pleasure.
Thank you, Jim. I worked in the VA for some time, and one of the biggest challenges that you face, as you know, is that the complexity of a lot of the veterans who suffer from PTSD with the drug addiction and alcohol and smoking. And the challenge is that when you're addressing PTSD in patients who have all these other concomitant addiction, how do you deal with that? I think smoking and alcohol and lifestyle, how do you deal with that? There are a lot of barriers to setting up an exercise program with someone who is.
So the question is, when you're dealing with populations of traumatized folks that have high degrees of comorbidity, so multiple levels of substance use, addiction, PTSD, and co-occurring mental health disorders, how do you deal with that? Does it add additional challenge? I mean, of course it adds additional challenge, and I don't have a good answer of what would be the best way to implement that, because I'm not a dissemination implementation scientist, but I would say it's worth trying, because we know that exercise is good for addiction. We know that it's not someone who's suffering from alcohol addiction or nicotine addiction. There's no reason for us to withhold exercise from them. And one of a common sort of reason for relapse to substance use is experience of withdrawal symptoms, negative affect, feeling not so good, because then you go back to your substance to feel good or get right. Well, what does exercise do? It could be a buffer for negative affect. As I demonstrated a moment ago, exercise can make people good. So maybe it could be a tool to build resilience as a tool in the tool belt as they're going through using their medications, going to psychotherapy, going through those programs to help them with their first line treatment. I think it is a necessary tool in the tool belt, because those folks that you named also suffer from a higher risk of diabetes, heart disease, stroke, all sorts of other not so good things.
Thank you, James. As there are several mental health professionals here, counselors and psychologists, I'm wondering if you can share whether there are precedents, just like social workers may be embedded in the primary care setting. Are there precedents or models where fitness professionals or personal trainers or exercise specialists are embedded in community mental health settings?
I mean, Simon talked about that. I think we have some, in the US, we like to silo our healthcare. I'm sorry, let me restate that. Are there examples of fitness providers, healthcare providers embedded into the mental health care settings in different healthcare systems? I think we have an interesting model of healthcare in the US where we like to compartmentalize the disorder and then treat just that disorder and isolate it. And it's oversimplification. We put things in boxes. PTSD, along with all like depression, these are systemic disorders that affect your whole body. You break your leg, at work, and then go on workman's comp, and then you can't perform, you have a reduction in your ability to perform your role in your, like as a healthcare, or as a worker at home, you're likely to suffer not only those physical effects, but your mental health effects. You may be depressed, just to shorten that up. But I think there are very good examples. The VA is a multidisciplinary healthcare system that has lots of embedded healthcare providers. It's not perfect. I think you could look at that and then look outside the US. And I'm out of time, so I'm gonna give myself the hook.